Welcome back to the Deep Dive, the place where we take the most challenging, high-stakes source material and, well, we turn it into knowledge that you can use immediately, especially when lives are on the line.
That's right.
Today, we are undertaking a really critical mission. It's an extensive deep dive into high-risk pregnancy. This is a field where, clinical precision isn't just valuable, it is absolutely essential.
It really is.
We're going to be focusing on how nurses manage these crises. And, just as important, how you can master this material for your licensure exams.
It is a fascinating and a very high acuity area of study. The materials we're working from today are incredibly comprehensive, and they're laser focused on risk conditions related to pregnancy.
Okay.
And before we really get into it, we have to pause and just extend our profound gratitude to Dr. Abdulkareem for providing these detailed and critical sources. They form the entire basis of our discussion today.
Absolutely. This material is it's designed to bridge that gap between what you read in a textbook and the life-saving judgment you need at the bedside.
Yeah.
So our mission today is explicitly twofold. First, we need to pull out the absolute non-negotiable knowledge nuggets. We're talking about priority concepts, reproduction, and safety in high-risk maternity care.
And we're not just reciting facts here. We're really trying to figure out the why behind a critical intervention.
Right. And second, and this is maybe the most strategic part, we're going to analyze exactly how this high acuity knowledge is translated, how it's framed, and how it's tested in a high-pressure setting, specifically the NCLEX-RN.
The NCLEX demands prioritization. It's all about what you do first. And we want to arm you, the listener, with the ability to think like the person who writes the test.
Okay, let's unpack this. We are tackling the life or death distinctions that you absolutely have to master. We need to know how to quantify blood loss when seconds are ticking away. We need to identify that single most dangerous assessment finding that signals, an impending neurological disaster.
And we're going to spend a lot of time on how you spot the correct high-priority answer when a test question throws 4 technically true but really misleading options at you.
Yeah, exactly. Let's start right at the beginning. The high-risk issues of early pregnancy, focusing on those complications that show up with bleeding and abnormal location.
This is a great place to start. When a client presents in the first trimester, especially with any kind of bleeding, the clinical spectrum is just huge. The nurse's first job is rapid triage. You have to move from something benign and self-limiting to a true surgical emergency.
And that bleeding is the big red flag, isn't it? It's the thing that says, stop, we need to investigate this right now.
It's the signal. And even that first distinction can save a lot of panic.
Oh, for sure. So many people confuse implantation bleeding with an early period, and that can be psychologically exhausting for someone who's hoping for a pregnancy.
That's so true. Implantation bleeding is really defined by its timing and its character. It typically happens about 10 to 14 days after conception, so right around when a period would have been due.
Which is why it's so confusing.
Exactly, but structurally, it's much lighter than menses. It's usually described as spotting, and it lasts a very short time, maybe 1 or 2 days max. The key takeaway for the nurse is just recognizing that this is a localized, non-pathological event.
Okay, so once we've figured out the bleeding is likely pathological, the list of potential causes just explodes. It ranges from, local irritants to massive systemic threats.
It does. The causes can be anything from minor cervical issues like polyps or trauma, vaginitis, all the way up the severity scale to an ectopic pregnancy, a molar pregnancy, or even conditions that usually cause later bleeding but can start early, like placenta previa.
And what about hormones?
That's a great point. It's also important to note the hormonal angle. Low serum progesterone is a surprisingly common and often reversible cause of early spontaneous miscarriage. If you catch it and treat it with supplemental progesterone, sometimes that threatened loss can be stabilized.
Okay, let's nail down the precise terminology around spontaneous abortion or miscarriage. It's so essential for communicating with the team and just for understanding the care plan.
It is. The classifications really hinge entirely on 2 things: the status of the cervical os, and whether or not tissue has been retained.
So where do we start?
We start with the threatened classification. So in this case, you have spotting, you have some cramping, but the key diagnostic sign is that the cervical os remains closed. There is no cervical change.
No dilation, no effacement.
Exactly. The pregnancy is just threatened because there is still a chance it can continue. The management is often just waiting and watching.
But the whole game changes once that cervix starts to change.
The prognosis shifts immediately. When the spotting and cramping continue, and now the cervix has begun to dilate and efface, the process is considered inevitable. At this point, the expulsion process is very unlikely to be reversed.
And from there, it's about what has actually been expelled, right?
Precisely. Next, we look at an incomplete abortion. This means some products of conception have passed out, but some crucial tissue, and it's often the placenta, is retained inside.
And that retained tissue presents a massive risk, doesn't it? It's not just that the pregnancy is over, it's a huge hemorrhage and infection threat.
Absolutely. That retained tissue acts as a perfect home for infection, and it also prevents the uterus from contracting effectively. That can lead to a potentially massive post-loss hemorrhage.
So that usually requires surgery, like a DNC.
Yes, a dilation and curettage, or DNC, is usually necessary. Then you have a complete abortion, which means all the products have been fully expelled. This simplifies the immediate physical care, though of course the emotional care is still paramount.
And what about the two types that signal either a chronic issue or a more hidden internal risk?
So that would be a missed abortion, which is often clinically silent at first. The fetus has died, but the products of conception just remain inside the uterus.
What's the danger there?
The danger is that if they are retained for too long, say for weeks, the cruciates begin to break down and they release thromboplastin into the bloodstream. This is a major trigger for disseminated intravascular coagulation, or DIC, which we'll talk about later.
A nightmare scenario.
It is. And finally, you have habitual abortion, which is the clinical term for a client who has tragically experienced 3 or more successive spontaneous miscarriages.
Okay, so given the huge risk for hemorrhage and shock in any of these active bleeding scenarios, let's focus on the absolute priority interventions. What is the NCLES testing when it asks about quantifying blood loss?
It's testing your clinical judgment and your objectivity. I mean, yes, the client needs bed rest, you have to check vital signs constantly, and you have to save any expelled tissue for the pathologist.
But there's one thing that always seems to trip people up.
Yes. The non-negotiable critical technique is the need for counting and weighing perineal pads.
Explain that for us. Why is weighing so much better than just, looking at it and estimating? Why is that specific technique so critical?
Because visual estimation is wildly subjective. It's so inaccurate, especially in a stressful emergent situation. What one nurse calls light bleeding, a resident might call moderate. It's not reliable.
So the weighing gives you hard data.
It gives you objective, quantitative data. The mathematical principle is simple and universal. 1 gram of weight gain on that pad equals 1 milliliter of blood loss.
Ah, I see.
By weighing the pads, you get a real measure of the rate of hemorrhage. If a client is losing 100 grams an hour, that's 100 milliliters of blood loss per hour. That allows the medical team to definitively track the clinical trajectory and make a solid decision about volume replacement or surgical intervention. It's a core safety competency.
And the final critical intervention for any early pregnancy loss, regardless of the classification, it really focuses on future safety, right? The need for Rho-D immune globulin.
This is a definitive, irreversible intervention with massive implications for future reproductive health. It's a huge NCLEX concept.
Why is it so important?
If the client is Rh negative and the pregnancy is lost, or even just threatened, they must receive Rho-D immune globulin, or RhoGAM, as prescribed. This prevents maternal isoimmunization.
Which is when the parent's body creates antibodies against Rh-positive fetal blood.
Exactly. And those antibodies would then threaten every single subsequent Rh-positive fetus. So this intervention is all about addressing the long-term, non-immediate safety of the client's future pregnancies.
Okay, so moving past spontaneous losses, let's shift focus to abnormal implantation sites. The classic one being ectopic pregnancy.
Yes, an ectopic pregnancy is the implantation of the fertilized ovum anywhere outside the uterine cavity.
It's incredible how many places it can happen. The abdomen, the ovary, the cervix. But the huge majority of them happen in the fallopian tube.
The most common site and the most critical one in terms of the risk of rupture is the ampulla of the fallopian tube. The tube is it's a narrow, delicate structure. It simply cannot support the rapid growth of a placenta and an embryo.
So what's the initial presentation like?
Often it's a missed period, some abdominal pain, and frequently dark red or brown spotting, which is just old blood.
Okay, but here's where it gets really interesting. And this is the high alert moment for clinical judgment. The signs of an imminent or actual rupture. This is a full-blown surgical emergency, and there's one sign that is the classic NCLEX giveaway.
That's right. The pain, which might have been mild before, suddenly increases dramatically. You start looking for signs of acute hypovolemic shock tachycardia, hypotension. But the hallmark, the most distinctive finding that demands immediate recognition and action, is referred shoulder pain.
That referred pain is such a strange physiological phenomenon. Can you walk us through the mechanism of why that happens?
It seems counterintuitive, but it's such a crucial sign. When the fallopian tube ruptures, blood starts to fill the abdominal and pelvic cavity. This free blood pools and begins to irritate the diaphragm.
Okay.
The sensory nerves that innervate the diaphragm, specifically the phrenic nerve, actually originate high up in the cervical spine. Because of this shared neural pathway, the brain misinterprets the diaphragmatic irritation as pain that's originating in the shoulder tip.
Wow. So identifying that shoulder pain is basically the equivalent of yelling stat surgery in the clinic.
We've got it. The intervention often involves rapid preparation for surgery, a laparotomy, to stop the hemorrhage. But if you catch it really early, there is a medical alternative.
What's that?
If the pregnancy is small and hasn't ruptured, the client might be treated with methotrexate. This is a potent folic acid antagonist. It interferes with DNA synthesis, and it halts the rapid division of the trophoblast cells.
So the body just absorbs the tissue.
Right. It allows the body to absorb the non-viable pregnancy tissue. And again, we have to repeat, regardless of surgical or medical management, if the client is Rh negative, they absolutely require Rho-D immune globulin.
Let's pivot to the other dangerous location-based abnormality, hydatidiform mole, or gestational trophoblastic disease. This is the condition that replaces the pregnancy with that grape-like cluster of abnormal tissue.
Yes, and this diagnosis carries a lot of weight, not just because it ends the pregnancy, but because that tissue has the potential for rapid malignant transformation into something called choriocarcinoma.
Which is a type of cancer.
A very aggressive one. And the assessment findings are classic NCLEX highlights because they directly contradict what you would typically expect in a normal pregnancy.
So what are the big three hallmark findings that the test writers really rely on?
First, despite having placenta-like tissue growing, the fetal heart rate is not detectable. There is no fetus. Second, the client often experiences a really exaggerated form of pregnancy symptoms, like severe, persistent nausea and vomiting, which we call hyperemesis gravidarum.
And the third one is about timing, right?
Exactly. This is maybe the most crucial timing detail. The client may present with signs of preeclampsia, so elevated blood pressure and related symptoms, but before 20 weeks gestation. Preeclampsia before 20 weeks is highly unusual and demands an immediate investigation for gestational trophoblastic disease.
And the physical exam often shows a big discrepancy in size.
Yes, the uterus is often significantly larger than you would expect for the gestational date. And that's because of the rapid proliferation of all that molar tissue. Lab confirmation will show incredibly high HCG levels, often over 100,000, and the diagnostic ultrasound reveals a characteristic snowstorm pattern.
The main treatment is uterine evacuation, but the follow-up care after that is, it's arguably the most demanding part and requires strict client compliance.
It is a marathon, not a sprint. Because of that risk of malignant recurrence, the client has to undergo rigorous HCG monitoring. We check levels every 1 to 2 weeks until they return to normal, and then they're monitored every 1 to 2 months for a full year.
Wow, a full year.
A full year. And the absolute critical piece of patient teaching here, the one the NCLEX hammers home, is that reliable birth control is required for that entire year.
Okay, so why the strict birth control requirement? What's the mechanism there?
It's all about the HCG. If the client were to become pregnant again during that surveillance year, the rising HCG from the new healthy placenta would completely mask any potential increase in HCG that's caused by a recurrent malignancy.
You'd lose your tumor marker.
You would lose your primary non-invasive tumor marker. So to ensure that the cancer surveillance is effective, pregnancy must be prevented until that whole surveillance period is complete. It is a non-negotiable safety measure tied directly to malignancy risk.
Okay, let's transition now to conditions that really force the maternal body, particularly its circulatory and hematologic systems, past their limits. Pregnancy itself is a massive physiological stress test.
It is the ultimate stress test. The body has to accommodate a tremendous increase in volume and output. The blood volume peaks significantly between 32 and 34 weeks. And for a client who has a pre-existing condition, their heart may simply run out of reserve capacity to handle that added load.
And our sources give a really clear, high-yield categorization of cardiac risk. This immediately dictates the management strategy and predicts maternal mortality. This is exactly the kind of knowledge the NCLEX uses to test prioritization.
This stratification is vital. Group I represents the lowest risk, with about a 1% mortality rate. This includes uncomplicated lesions like an atrial septal defect or a successfully corrected tetralogy of Fallot. These clients generally have excellent outcomes.
Then the risk jumps significantly to Group 2.
Group 2 carries a 5 to 15% mortality risk. This includes conditions like aortic stenosis or Marfan syndrome with a normal aortic root. Management here requires much stricter vigilance and activity limitation.
But the highest risk group, Group 3, is terrifying. A 25 to 50% mortality rate. That's just staggering. Why are these conditions so devastating in the context of pregnancy?
This is where we have to link the pathophysiology to the mortality. Group 3 conditions include pulmonary hypertension, complicated coarctation of the aorta, and Eisenmenger syndrome. The reason they're so lethal is that they fundamentally involve either a fixed cardiac output or severe pulmonary vascular resistance.
So the heart just can't keep up.
It can't. When the body tries to increase volume and flow, which is mandatory in pregnancy, the heart cannot overcome that fixed high resistance. That leads to rapid, catastrophic right-sided heart failure and potentially death. For a client in this group, pregnancy must be very carefully considered.
So the nurse's role, then, is to spot the absolute earliest sign of decompensation before it reaches a crisis level. What are the subtle clues we're looking for?
We are looking for the heart failing to compensate for all that fluid and volume. So a persistent cough, unexplained respiratory congestion, a sudden onset of dyspnea, or just increased frequency of it. Overwhelming fatigue that isn't relieved by rest, palpitations, persistent tachycardia, non-pitting peripheral edema, and chest pain.
So the resulting nursing interventions have to be focused entirely on reducing that cardiac workload.
The central principle is absolute conservation of energy. This means strictly limiting activity, ensuring periods of sufficient rest, and actively preventing two major physiological stressors.
What are those?
First, you have to prevent anemia, because a lower oxygen carrying capacity forces the heart to beat faster and harder. Second, you must prevent fluid overload. This is why a low-sodium diet is critical. It reduces the overall fluid volume that the compromised heart has to pump. We have to vigilantly monitor for pulmonary edema.
Which is fluid backing up into the lungs.
Exactly. And the final act of this stress test is labor. How does the nurse guide a client with heart disease through delivery while minimizing cardiovascular strain?
This must be incredibly delicate.
It is. We must maintain continuous cardiac and fetal monitoring. The client needs frequent vital sign checks. Positioning is managed to maximize cardiac function, usually side-lying with the head and shoulders elevated. Pain management is introduced early to prevent tachycardia.
And this brings us back to that critical detail about pushing, avoiding the Valsalva maneuver. This is a highly focused teaching point.
It is paramount. The nurse must coach the client to use controlled, open glottis pushing efforts. The Valsalva maneuver, which is the act of holding your breath and bearing down forcefully, what most people think of as typical pushing, causes a dramatic temporary increase in intrathoracic pressure.
So what's the danger in that?
When the client releases that pressure, there is a sudden, massive rush of blood back to the heart. It's a preload surge. In a heart that's already struggling, that sudden volume overload can trigger acute cardiac failure, arrhythmia, or even death. The controlled pushing technique minimizes that dangerous physiological swing.
Let's move to DIC, which is truly a nightmare scenario. It represents the total collapse of the body's clotting system. It's this terrifying paradox where the patient is both clotting excessively and bleeding uncontrollably.
That paradox really defines the condition. It's often called consumptive coagulopathy. The process begins when a massive systemic insult-like sepsis, or placental separation, releases huge amounts of procoagulant substances into the bloodstream.
So the clotting cascade gets activated everywhere at once.
Across the entire microcirculation, small thrombi or microclots form everywhere. And in doing so, they consume platelets and clotting factors so rapidly and so extensively that they are just instantly depleted.
So all the resources you need to stop a real bleed are used up, making these useless, dangerous little clots.
Exactly. So when the client then actually needs to stop a bleed, say, from an IV site or minor tear during labor, the resources are gone. The client is left with a profound deficiency of clotting factors, which leads to the secondary catastrophic problem, uncontrolled hemorrhage.
The NCLEX frequently tests the predisposing conditions, the root causes that set off this massive systemic insult.
Yes, the most common obstetrical triggers include high acuity emergencies. Abruptio placentae is the most common cause. Then you have HLLP syndrome, Intrauterine fetal death if the tissue is retained for weeks, severe sepsis, and massive postpartum hemorrhage. The common thread is widespread vascular damage or tissue necrosis.
And connecting the pathophysiology to the assessment findings is so crucial. How do we spot that paradoxical bleeding?
You see uncontrolled bleeding from multiple sites, 4V insertion points, surgical sites, the gums, the nose. You look for skin signs of factor depletion, bruising, petechiae, which are tiny pinpoint hemorrhages, purpura, and ecchymosis, which are larger bruises. And you also check for occult blood in urine, stool, or vomit.
And the lab results tell the story of that exhausted clotting cascade.
The labs confirm the consumption. You will see decreased fibrinogen and a very low platelet count. Crucially, the blood takes longer to clot because the factors are used up, so you see an increased prothrombin time, or PT, and an increased partial thromboplastin time, or PTT.
And what's the definitive marker?
The absolute definitive marker is an increased level of fibrin degradation products, or FDPs, also called D-dimer. These are the broken down remnants of all those microclots being dissolved by the body.
So interventions focus on immediate life support and, eliminating that original trigger.
Safety and perfusion are the twin priorities. The underlying cause has to be removed, so immediate delivery or evacuation of retained tissue. While you're stabilizing, you administer oxygen, volume replacement, and specific blood components like platelets or cryoprecipitate.
And what's a life-saving intervention the nurse is specifically monitoring for?
Renal perfusion. DIC can trigger acute renal failure, so the client must maintain a minimum urine output of at least 30 milliliters/RR. If that output drops, it signals dangerous hypoperfusion to the kidneys.
Okay, let's shift gears to Section 3. We're going to explore conditions that alter the core chemistry and defense systems of the pregnant person. Diabetes mellitus and infectious diseases. These often require really sophisticated anticipatory management.
Yes, and managing diabetes during pregnancy is uniquely challenging because the client's insulin requirements are not static. They shift dramatically, especially because of the fluctuating hormonal environment. Understanding this physiological trend is absolutely vital, particularly for the NCLEX.
Let's lock that physiological shift down because it's a classic test question. What happens in the first trimester?
So in the first trimester, due to increased pancreatic sensitivity and often low circulating placental hormone levels, insulin needs typically decrease. This is often when the client might experience more hypoglycemic episodes.
But that completely flips in the second and third trimesters.
It does, a complete 180. This is the period of high placental activity. Hormones like human placental lactogen and progesterone act as strong anti-insulin agents. They trigger a state of significant insulin resistance.
So to compensate, insulin needs have to go way up.
Exactly, sometimes dramatically, just to maintain normal blood sugar. The test writers love to check if you know this crucial reversal.
And the fetus adds another layer of complexity to this whole glucose dynamic.
It does. The fetus is continuously pulling glucose from the parent's blood, which predisposes the parent to hypoglycemia, especially overnight. But then the fetus, which is receiving all that glucose, starts producing its own insulin. This leads to fetal hyperinsulinism.
And what are the resulting risks for the newborn of a diabetic parent?
That fetal hyperinsulinism acts like a growth hormone, leading to excessive fetal size, or macrosomia, a large for gestational age baby. Then, post-delivery, when that constant supply of maternal glucose is suddenly cut off, the newborn's pancreas is still overproducing insulin,
Which leads to a crash.
a severe and rapid neonatal hypoglycemia. Other risks include hyperbilirubinemia and respiratory distress syndrome.
Okay, regarding gestational diabetes, or GDM, the screening process itself is a common point of focus for tests.
Yes, the two-step process. The initial screening is the 1-hour glucose challenge test, the GCT, which is performed between 24 and 28 weeks. This test does not require fasting.
And what's the critical threshold for an abnormal result?
140 milligrams per deciliter or greater. If the result is abnormal, then the definitive diagnostic test is the 3-hour oral glucose tolerance test, or OGTT, which does require fasting and measures glucose levels at multiple intervals.
And what are the strict, non-negotiable target blood glucose levels for management during pregnancy?
The clinical targets are very tight. Fasting blood glucose has to remain below 95. The 1-hour postprandial, so after meal levels, must be below about 130 to 140. Management starts with diet, carbohydrate control, and moderate exercise. If those fail, then insulin or oral agents are initiated.
And then comes the postpartum period, which is the final rapid metabolic correction.
This is a massive safety alert. Once the placenta is delivered, those hormones that were causing insulin resistance, they vanish almost instantly. So there's a precipitous decline in insulin requirement.
So the big risk is hypoglycemia.
Yes. Many birthing parents, especially those with GDM, may not require any insulin for the first 24 hours postpartum. The nurse must monitor extremely closely for rapid onset maternal hypoglycemia.
Okay, let's move on to infectious agents. These pose unique risks because of their ability to cross the placental barrier and cause severe, lifelong congenital defects. Let's break down the classic Tarasiege panel.
Right, starting with T for toxoplasmosis. This is a parasite that's transmitted via ingesting raw or undercooked meats, or from handling the litter of infected cats. Infection can cause miscarriage or hydrocephalus. The nursing priority is all about client education on safe food handling and sanitation.
So avoiding raw meat and having someone else change the cat litter box.
Exactly. R is for rubella, or German measles, which is particularly dangerous in early pregnancy.
Why is that?
Rubella is highly teratogenic. It causes severe defects if it's contracted in the first trimester, defects in the eyes, like cataracts, the heart, and the brain. The critical assessment is the client's immunity status. If a client is non-immune with a titer less than 1 to 8, they have to be vaccinated postpartum.
And here's the key teaching moment, right?
This is it. Because the rubella vaccine is a live attenuated virus, the client must use reliable contraception and wait 1 to 3 months before attempting to conceive again. This is a very frequently tested concept.
Then C for cytomegalovirus, or CMV.
CMV is often transmitted through close personal contact, like exposure to children's saliva or urine. The pregnant parent can be completely asymptomatic, which leads to high rates of unnoticed transmission.
But the consequences for the fetus are severe.
Very severe. Intrauterine growth restriction, microcephaly, blindness, hearing loss, seizures. Contact precautions are required for both the parent and the neonate.
And H stands for herpes simplex virus, HSV.
HSV usually presents with draining, painful vesicles on the external genitalia, the vagina, or the cervix. The major risk is transmission to the baby during a vaginal delivery if the virus is active. So suppression therapy with a cyclover or valacyclover is often started late in pregnancy to prevent an outbreak during labor.
Okay, so what is the absolute non-negotiable safety protocol for labor management if a client shows up with active lesions?
The nurse has to avoid all invasive procedures, especially the single most dangerous action, which is vaginal examinations. If active lesions are present in the birth canal, the risk of neonatal transmission is just unacceptable.
So it's an automatic C-section?
A cesarean section is required if active lesions are visualized at the time of delivery. The risk of transmission simply outweighs the benefits of a vaginal birth.
Okay, moving beyond TORCH, let's discuss human immunodeficiency virus, or HIV. The management plan here is multi-stage, and it's designed solely to reduce the risk of perinatal transmission.
This is a complex but a highly successful protocol. The goal is to drop the maternal viral load as low as possible. This involves a 3-drug, highly active antiretroviral therapy, or HAART, antepartum, and often intravenous zidovudine intrapartum.
And the delivery decision itself is viral load dependent. What's that threshold?
A vaginal birth is considered acceptable only if the maternal viral load is confirmed to be less than 1,000 copies per ml. If it's greater than that, or if it's unknown, a scheduled cesarean section is recommended to minimize the infant's exposure to maternal blood and fluids.
And the immediate neonatal intervention is proactive.
Yes. The neonate must receive zidovudine syrup for 6 weeks, starting within 2 hours of birth. This is prophylaxis to prevent the virus from establishing itself. And the final critical postpartum intervention, the one the NCLEX uses to test your knowledge of transmission routes, is that breastfeeding or chest feeding is contraindicated or strictly restricted.
Because the virus can be transmitted through milk.
Precisely. The nurse has to counsel the parent on the necessity of bottle feeding.
Now, let's pivot to hepatitis B management, because the postnatal safety protocol, while it's also rigorous, differs when it comes to the feeding recommendations.
Right. This is a key distinction. HBV is transmitted through various body fluids, blood, saliva, semen, and also across the placental barrier and possibly through milk. The neonatal interventions prioritize infection control and immediate immunization.
So we minimize vaginal exams, quickly remove maternal blood from the neonate.
Yes, and the absolute key nursing step that has to happen before anything invasive.
What is it?
It is the sequential order of care. The nurse must bathe the neonate before any invasive procedures. That includes heel sticks, circumcision, or giving the required injections.
And the logic there is to wash off any surface contamination.
Exactly. You wash off the blood and fluid contamination from the skin surface, and that prevents the virus from entering the body through the microscopic breaks in the skin caused by injections.
And the big difference from HIV is in the feeding recommendation.
Correct. The neonate immediately receives both hepatitis B immune globulin, or HBIG, and the first dose of the hepatitis B vaccine. This passive and active immunization provides adequate protection. Therefore, after that protocol is followed, breastfeeding or chest feeding is supported and safe. Knowing that nuanced difference between HIV and HBV is a high-yield memory hint for any exam.
Okay, we are now moving into the late pregnancy danger zone. This is where conditions become acute, demanding immediate delivery and constant monitoring of maternal neurological and cardiovascular stability.
Yes, this section covers preeclampsia, eclampsia, and what I call the Great Divide in obstetrics, placental placement and separation issues. Mastering the progression of hypertensive disorders is just fundamental to safety.
The progression is clearly defined. Normal blood pressure, elevated, stage 1 or 2 HDN, gestational HDN, which starts after 20 weeks without proteinuria, preeclampsia, and finally eclampsia, which is defined by the onset of a seizure.
Preeclampsia is essentially a disease of widespread systemic vasospasm and endothelial dysfunction. The initial assessment findings include persistent hypertension, swelling of the face and hands, headache, visual changes, and that very distinct upper abdomen or shoulder pain, epigastric or right upper quadrant pain that signals liver capsule irritation.
Let's hit that critical NCLEX update regarding the diagnosis. Historically, proteinuria was the defining characteristic of preeclampsia.
That concept is shifting dramatically. Our source material emphasizes that proteinuria is no longer considered a reliable indicator of preeclampsia severity or diagnosis. We now know that severe end organ damage can occur without significant protein loss. The focus now is entirely on recognizing the severe features.
So preeclampsia with severe features is the immediate safety alert. What are the criteria that screen crisis?
We look for a persistent elevation in blood pressure, specifically 160 over 110 or greater. We look for lab markers of organ failure, platelets dropping below 100,000, elevated liver enzymes, and oliguria, so severely reduced urine output. And the neurological signs are paramount: a severe unremitting headache, visual disturbances, and critically evidence of central nervous system irritability.
And that CNS irritability is measured by deep tendon reflexes, or DTRs.
Precisely. We assess DTRs on the 0 to 4 plus scale, and hyperreflexia, so 3 plus or 4 plus reflexes, especially with clonus, which is that rhythmic jerking after you dorsiflex the foot, that is the absolute non-negotiable NCLEX alert. It indicates the CNS is severely irritable and hyperexcitable. It signals an impending, possibly minutes away, eclamptic seizure.
And we also have to mention HLLP syndrome, which is often a severe complication.
HELLP is an acronym for hemolysis, elevated liver enzymes, and low platelet count. It's a manifestation of severe preeclampsia, and it often results in internal liver hemorrhage or rupture. It is a medical emergency that demands immediate delivery.
Given that impending seizure risk, the cornerstone of therapeutic intervention is magnesium sulfate.
Yes, and mag sulfate is not an antihypertensive drug. It is a CNS depressant, given specifically to prevent seizure activity. Management revolves around diligent monitoring. Positioning the client in the lateral position is important, and monitoring I&O is non-negotiable, maintaining that 30 milliliter minimum.
But the use of mag sulfate is dangerous because its therapeutic window is incredibly narrow. It has a high alert status for toxicity.
This is a major NCLEX focus. The nurse has to constantly monitor for signs of mag toxicity. The immediate most common sign is the disappearance of the reflexes depressed or absent DTRs. Following that, you see decreased urine output, and the most life-threatening sign is respiratory depression or arrest.
So practically speaking, how often should a nurse be assessing those DTRs, and what's the single most common mistake made in this setting?
In the acute phase, DTRs have to be assessed frequently, often every 15 to 30 minutes, right alongside respiratory rate and urine output. And the most common mistake, and what the NCLEX tests against, is failing to correctly link the assessment findings to the antidote.
Which is calcium gluconate.
Yes. Because mag sulfate can cause respiratory paralysis, the nurse must ensure that the antidote, calcium gluconate, is not only ordered but is readily available at the bedside. I mean, drawn up, visible, ready for immediate administration if toxicity is suspected. That is a non-negotiable safety check.
Okay, so if the client does progress to eclampsia and has a seizure, The nursing intervention immediately shifts to acute crisis management.
Safety is everything. The nurse must remain with the client, call for immediate help, secure the airway, turn the client onto their side to prevent aspiration, administer oxygen, and protect the client from injury. You have to stabilize before you can deliver.
Finally, let's turn to the two leading causes of third trimester hemorrhage, placenta previa and abruptio placentae. You've noted the NCLEX loves to test the differences between these two because the management is almost entirely opposite.
This is the great divide. In placenta previa, the placenta has implanted improperly in the lower uterine segment, potentially covering the cervical S. The tissue is simply in the wrong place.
And what are the two core diagnostic assessment findings for previa?
The first is the color and quality of the bleed. It is a sudden onset of painless, bright red vaginal bleeding in the last half of pregnancy. The blood is bright red because it's fresh. The second is the uterine palpation. The uterus is characteristically soft, relaxed, and non-tender.
And the absolute safety contraindication. This is a core NCLEX question.
The absolute contraindication is the manual pelvic examination, a digital or speculum exam. Because the placenta is lying right over or near the cervical opening, disturbing that area could trigger immediate catastrophic hemorrhage. Management is absolute bed rest and usually a cesarean section.
Now, let's contrast that sharply with abruptio placentae, which is the premature separation of a normally implanted placenta from the uterine wall.
The clinical picture reverses completely. The bleeding is typically dark red vaginal bleeding. Often, the separation means the blood is trapped, so it's concealed hemorrhage. Crucially, the separation causes intense pain. Assessment reveals marked uterine pain and tenderness, and critically, the abdomen will be rigid or board-like because of blood penetrating the uterine muscle fibers.
So abruption is often tied to fetal distress and maternal shock?
Yes. Intervention is rapid stabilization followed by delivery. High-flow oxygen, IV fluids, blood products. Delivery has to happen ASAP. And because of the high risk of vascular damage, the nurse has to proactively monitor for signs of DIC postpartum.
Pain, rigidity, dark blood versus painless, soft uterus, bright blood. That is the diagnostic endpoint.
You've got it.
We have covered the critical content. Now, let's pivot our focus entirely to the NCLEX mindset. Knowing the facts is one thing. Applying them under high pressure, understanding the test writer's logic, and avoiding the attractive distractors, that is true strategy. We are now analyzing the structure of these high-stakes questions.
This is all about application and prioritization. The NCLEX, especially in high-acuity maternity, forces you to choose the option that ensures the most immediate maternal or fetal safety. The correct answer is always the one that addresses the greatest anticipated risk.
Okay, let's start with identifying a sign that preeclampsia is worsening. Question 2. The scenario presents 4 options. 3 are generally stable or resolving findings, increased urinary output, resolved edema, a baseline BP. The 4th is headache and blurred vision. You have to pick the most dangerous sign.
This tests immediate prioritization of neurological safety. The NCLEX loves to use false indicators of stability as distractors. Look at those stable options. Increased urinary output, resolved edema. These are signs the patient is actually improving. They tempt the test taker who only remembers general symptoms.
But the real danger is neurological.
The single truly dangerous sign, the one that indicates CNS damage and requires immediate medication or delivery, is the headache and blurred vision. That signals increased intracranial pressure and impending seizure activity. You have to filter out the stable data to find the acute neurological threat.
This principle of anticipating the worst complication also applies to question 4, which asks what finding is most closely associated with a complication of preeclampsia. And the answer involves bleeding, specifically in the gums, petechiae, or purpura.
Right, because this tests your ability to connect preeclampsia to its most catastrophic hematologic complication, which is DIC. Severe preeclampsia causes massive vascular damage. That damage triggers the DIC cascade. Therefore, evidence of spontaneous uncontrolled bleeding, petechiae, purpura, bruising is the early warning sign of that catastrophic downstream threat.
So the test wants you to connect the dots. Preeclampsia leads to systemic damage, which leads to DIC, which leads to bleeding.
Exactly. If you understand the flow of the pathology, that answer becomes obvious over less severe findings like generalized edema.
Okay, let's look at strategy 2. Contraindications and questions that ask about a need for further teaching. This requires finding the error or the absolute contraindication.
When you see need for further teaching, or nurse would question which prescription, it means 3 options are correct and 1 is wrong or dangerous. Let's look at gestational diabetes, question 3. The client states 3 true things about diet, glucose checks, and reporting infections. But the incorrect statement is, I need to avoid exercise because of the negative effects on insulin production.
And that word avoid is an extreme qualifier that's often medically incorrect. The test writer relies on the student knowing that moderate exercise is actually beneficial.
Precisely. Exercise increases insulin sensitivity and helps lower blood glucose levels. Recognizing that extreme statement that she must avoid activity as misinformation is the key. You have to look for the option that represents a safety error or a massive misunderstanding.
The same mechanism applies to a threatened abortion. Question 12. The client correctly states they will count pads, avoid intercourse, and save tissue, but the error is the extreme promise. I will maintain strict bed rest throughout the remainder of the pregnancy.
Yes, because strict mandated lifelong bed rest is often not evidence-based, especially if the bleeding resolves. The nurse must recognize that this excessive self-prescription is the statement that requires correction. The NCLEX is teaching you to rely on evidence-based practice, not excessive intervention.
And the high-stakes contraindication, placenta previa, question 15. The question asks which prescription the nurse would immediately question.
This is a test of absolute safety. Options like drawing labs, performing an ultrasound, or applying a fetal monitor are necessary tasks. The life-threatening instruction is to obtain equipment for a manual pelvic examination. The test writer places necessary actions alongside the single lethal action, recognizing that a digital exam can trigger immediate exsanguinating hemorrhage in previa makes questioning that prescription the immediate correct clinical judgment.
Strategy 3. Infection control and transmission. High-risk infections often force the student to prioritize safety over emotional considerations, especially with parent-newborn bonding or feeding.
Take the HIV feeding question, question 1. Knowing the pathophysiology, the virus is transmitted through breast milk, dictates the nursing advice. You must prioritize minimizing transmission risk over supporting breastfeeding. Therefore, bottle feeding is the standard, safest recommendation. The NCLEX is testing your ability to make a difficult, safety-driven choice.
Now, compare that to hepatitis B, question 11, which tests the parent's knowledge of safe practices postpartum.
The correct choice here is the one that shows the parent understands detailed hygiene. It's the one that demonstrates superior knowledge of minimizing contact with blood and fluids. The birthing parent washes and dries the hands before and after self-care of the perineum and asks for a pair of gloves before feeding. The distractors will suggest less rigorous hygiene. The test writer chooses the option that shows the most comprehensive, detailed infection control knowledge.
Okay, strategy 4 is applying pathophysiology to care. This demands the student use the mechanism of the disease to justify a seemingly unrelated care measure.
We revisited cardiac disease in question 9, where the goal is avoiding the Valsalva maneuver. To avoid Valsalva, the client must avoid straining during defecation. Therefore, the required dietary instruction is, I need to drink adequate fluids and increase my intake of high-fiber foods.
So the NCLEX demands you connect that 3-step chain of physiological reasoning.
Exactly. Prevent constipation, to prevent straining, to prevent the Valsalva maneuver, to protect the heart. The distractors might focus on low-calorie intake or general vitamins, but only the fiber fluid choice addresses the specific cardiovascular risk.
And the most fundamental application of pathophysiology is distinguishing placenta previa from abruptio placentae, questions 14 and 18.
This is a memory hint you have to master. The NCLEX tests these two against each other using 2 variables, pain and uterine tone. Previa is painless, and the uterus is soft and relaxed. Abruption is characterized by pain, tenderness, and a board-like, rigid uterus. If you can confidently sort those 2 distinct presentations, you have mastered a high-acuity diagnostic differential.
And finally, the diabetes question, question 7, regarding insulin needs, testing that physiological shift we emphasized earlier.
Right. The question will offer a client statement that violates the known trend. Claiming, I will need to increase my insulin dosage during the first 3 months of pregnancy is the incorrect statement because insulin needs decrease in the first trimester. The test writer knows most people assume insulin needs only go up, so they use the first trimester reversal as a test of your detailed knowledge.
Okay, last one, strategy 5, risk factor clustering and management. This is about grouping multiple high-risk conditions to identify the single client at the most risk for a complication, like DIC in question 5.
Yes, you have to recall the major systemic insults that cause DIC. abruptio placentae, intrauterine fetal death, and severe gestational hypertension, or HELLP. The test writer will place these severe insults alongside common, less severe complications. The NCLEX demands you prioritize the conditions that cause massive, widespread vascular trauma.
Let's conclude with the management of the pregnant client who is obese. Question 13. This tests the ability to anticipate specific, multifaceted risks.
Obesity increases the risk for major complications, notably venous thromboembolism or VTE, and complications of surgical delivery. So the nurse has to anticipate specific interventions. The correct options highlight prevention: prophylactic subcutaneous heparin post-delivery, the use of sequential compression devices or SCDs, and increased monitoring and cleansing of surgical incisions. The need for an overbed lift for safe transfer is also a critical safety measure.
So an option suggesting less frequent wound care would be a major safety error.
Absolutely. The increased abdominal adipose tissue compromises incision perfusion and increases the risk of infection and wound dehiscence. So the nurse must ensure more frequent, meticulous monitoring and cleansing, not less. The test is about anticipating the complication and implementing the correct prophylaxis.
Okay, so to wrap this all up, we've dissected the essential knowledge that really underpins high-risk maternity care.
And mastery demands connecting that pathophysiology to safety-critical interventions. You have to immediately recognize the vast difference between the painless, soft uterus of previa and the painful, board-like uterus of abruption. That difference mandates a life-saving restriction avoiding a pelvic exam.
You have to know why you keep calcium gluconate at the bedside for mag sulfate toxicity and why monitoring urine output is so essential for preventing DIC-induced renal failure.
Right. And for passing the NCLEX, the strategy is about filtering out the stable data to find the single high-acuity threat. It's about prioritizing neurological safety when the client has a headache and visual changes. It's about recognizing the irreversible long-term consequence, like the need for ROJAM.
The maternity nurse has to be an advocate, a monitor, a pharmacist all at once, caring for two clients, the parent and the fetus, and prioritizing those immediate life-saving measures based on very subtle changes.
And that ability to move past memorization and truly internalize the reasoning behind every single intervention, why a manual exam in one case is lethal and why zidovudin is necessary in another, that is the goal of this entire deep dive.
So think about this as you move forward in your studies or your practice. We've seen how systemic conditions can fundamentally transform the physiological demands of pregnancy. What is the greatest hidden life-threatening crisis in your own field that you have to anticipate based only on a subtle physical finding or a minor change in a lab value? That is the essence of advanced clinical judgment.
Our profound thanks again to Dr. Abdulkareem for providing these essential source materials and guiding this critical deep dive. We wish you success in your pursuit of clinical mastery.
See you next time.